everybody, and welcome to the ILAE e-forum series of 2024. This is a forum about beyond the seizures in childhood onset epilepsies. For this forum, I'm joined by two colleagues well known in the area, Professor Elaine Wirrell, Professor of Child Neurology at the Mayo Clinic, and Professor Kette Valente, child neurologist from the University of Sao Paulo. I, of course, am Helen Cross, President of the International League Against Epilepsy, but also, of course, my bread and butter is I'm a child neurologist, also specializing in early onset complex epilepsies. Please note that during this, or at the end of this, we will be taking questions and answers, but we're not able to respond to questions referring to a specific case or patient. Just to highlight that this is part of our e-forum series, and we need to really thank our supporters. UCB is a gold sponsor for this series, and Jazz Pharmaceuticals, who are a bronze supporter. As I outlined earlier, we will have questions and answers at the end. If you can type your questions into the Q&A box at the bottom of the screen, we will then address those at the end of the series of presentations. At the very end, you'll be asked to complete a short survey, and we really appreciate the feedback with regard to that. Of course, what you've been provided for before the e-forum is a reading list, and then after the e-forum, after this presentation and question answer, it is being recorded, so will be available subsequently. But the other thing is there will be access to a mini case for consolidation of learning, the details of which will be forwarded to you at the end and at the finish of the webinar. Just to highlight that none of us with relevance to this particular seminar have conflicts of interest to declare. So, I'm going to do a brief introduction before we actually go into the presentations. And first of all, I'd like to put a question to you all, for which there will be a poll. What do you estimate the rate of neurobehavioral disorder in school-age children with epilepsy? And that's cognition and or behavior. 20%, 50%, or 80%? So there we can see that most of you, the majority of you, actually think that the rate of neurobehavioral disorder in children with epilepsy, and that's cognition and or behavior, is 20. The majority of you think it's 20%, shortly behind 50%, and only 15% of you think it's as high as 80%. So in order to address the answer to this, I'm just going to illustrate the results of a study that we took in the UK. And this was children with epilepsy in Sussex schools, which was a population-based study over a set geographical area with an aim of characterizing the prevalence and spectrum of difficulties in active epilepsy. And this was looking at cognition, academic achievement, and behavior, whether it was neurodevelopmental, psychiatric, and motor. And 74% of the eligible population underwent a full assessment. That's 85 children with epilepsy. And where possible, a DSM-4 consensus clinical diagnosis was made. And these are the main findings. And in order to address the question I put to you initially, 80% had at least one DSM-4 diagnosis and or cognitive impairment. So a relatively high rate, but only 33% of these had been previously diagnosed. So the rate is high, but many go unrecognized. Notably also, this is a population of school-age children, 42% displayed academic underachievement. And this slide just shows the range of DSM-4 criteria diagnoses. You can see autistic spectrum disorder, 21%. You can, blue is actually previously diagnosed, gray, those in the general population. ADHD, attention deficit hyperactivity disorder, DCD, developmental coordination disorder, depression, and anxiety. So the rates in children with epilepsy are relatively high. And one of the key questions, of course, is can we influence outcome? Now, the first issue is, of course, recognition, but then after that, can we actually ultimately influence outcome? Of course, the underlying cause of the epilepsy is going to have an impact, but the ongoing discussion is how much the epilepsy, seizures, epileptiform activity are having an overall influence on outcome. And ultimately, that question from parents is how about the medication? When we start off with the epilepsy, we've long talked about the term epileptic encephalopathy. The epileptic activity itself contributing to cognitive and behavior impairments beyond that expected from the underlying pathology alone. And of course, when we describe this, we therefore have the perception that's at least preventable, if not reversible. This was defined as a concept in the ILAE classification proposal in 2010 as a concept that could apply, of course, to any epilepsy. And of course, the more complex the epilepsy, the more severe this may be. But we recognize that in some of the epilepsies, if not many of the epilepsies, cognitive and behavioral impairments are not all due to the epileptiform activity. And this is perhaps a misnomer when people talk about epileptic encephalopathies. The perception is if it is all due to the epilepsy, why can't we reverse it? Or indeed, at least make it, if we do something with the epilepsy, maybe it'll all go away. But actually, many disorders, there's a contribution from the underlying cause. And so in the 2017 classification framework, the term developmental and epileptic encephalopathy was put forward and then subsequently confirmed in definition in the 2002 syndrome papers published from the Nosology Task Force. The term developmental and epileptic encephalopathies referring to disorders where there is a developmental impairment related to both the underlying etiology independent of epileptiform activity and the epileptic encephalopathy. So we have epileptic encephalopathy, where the disorders related to seizures and epileptiform activity have an impact on development. Developmental and epileptic encephalopathy, where the underlying cause and the epileptic activity will be having an impact. And then the developmental encephalopathy with epilepsy, where the epilepsy may not be that problematic, maybe occasional seizures, and the predominant part of the intellectual problems and cognitive and behavior problems are related to the underlying cause. And why does this matter? Well, because with developmental and epileptic encephalopathies, as we will discuss, it's not only the seizures that have an impact on the family. Neurodevelopment, the behavior, movement disorder, gut problems, feeding problems, sleep disorder are all part and integral of the disorder. And although we describe them as comorbidities, they are integral morbidities to the disorders. It's not all about the seizures. There are issues beyond the seizures about which we need to have discussion. And they, of course, all have impact on the quality of life, that of the child, the individual with the DEE, but also the family. So to start the discussion with regard to this, I'd like to introduce Elaine Wirrell, who's Professor of Child Neurology at the Mayo Clinic. And she's going to talk specifically about beyond the seizures in developmental and epileptic encephalopathies. Thank you, Elaine.
Thanks very much, Helen, and thank you for inviting me to be part of this. And I'm just trying to get the slides to go forward. There we are. Okay. So I'm going to be talking about specifically the developmental and epileptic encephalopathies and looking at beyond the seizures there. All right. So the objectives are, first of all, to say what non-seizure symptoms are seen in children with developmental and epileptic encephalopathies. How impactful are those on the patient's and the family's quality of life? Do these improve with early optimization of seizure control? And finally, how else can we actually help these families? So we're going to start with a poll on which of the following is true regarding children with developmental and epileptic encephalopathies. 1, other than intellectual disability, other comorbidities are rare. 2, developmental encephalopathy is expected to improve with earlier and more complete seizure control. 3, epileptic encephalopathy is expected to improve with earlier and more complete seizure control. And 4, early use of a precision therapy that targets the underlying pathogenesis is unlikely to benefit developmental or epileptic encephalopathy. So which of the ones are or which one is true? All right, so the majority of you said epileptic encephalopathy is expected to improve with earlier and more complete seizure control, and that is in fact the correct answer. All right, so let's talk about what is a DEE. So a DEE is a group of generally severe epilepsies that usually come on early in life. Not all, but most of them come on early in life. The seizures are very frequent, the EEG is very abnormal, and there are multiple non-seizure comorbidities. And as Helen had mentioned, there's really two concepts here. There's the developmental encephalopathy component, where we note that the delays are due to the underlying etiology for the epilepsy, not due to worsened seizures or frequent epileptiform discharge. And the developmental encephalopathy component cannot be improved with better seizure control. However, then we have the epileptic encephalopathy, and this is the component that is due to frequent seizures and frequent interictal discharges. And so the delay that we see is over and above what you would expect from the underlying cause alone. And this is the component that is potentially reversible with improved seizure control. But again, because these disorders come on in early life when neuronal plasticity is still happening, the neuronal networks are connecting, there really is likely a window of opportunity in that we really want to get these seizures under control as quickly as we can, if that is possible. So when we look at Dravet syndrome, which is one of the common developmental and epileptic encephalopathies, we know that there is intellectual disability, and we know that this is typically present by 2 or 3 years of age. Most children at the time they present with their first seizure are developmentally normal, but this comes on over time. And this was shown quite eloquently in the butterfly study, which was a prospective observational study. And then looking at the Vineland adaptive behavior scales and the Bayley scales of infant development, what we see is a decline in the standard scores over time. And this is not because they actually lose skills, but this is because they gain skills more slowly. And so the gap between children with Dravet syndrome and neurotypical children actually widens over time. In Dravet, we also see impaired speech and communication in approximately 80% of cases. About 15% of children will be nonverbal. Motor speech deteriorates often with age. We had already heard about the underdiagnosis problem, and that certainly is a concern amongst our DEEs as well. So autism spectrum traits are seen in about 2/3 of cases. About 1/3 of children are formally diagnosed, but again, underdiagnosis is probably a big concern. And then looking at behavior, 43 to 100% will score in the at-risk range. ADHD is formally diagnosed in 20%, but again, that's probably an underdiagnosis. Looking at motor skills, fine motor delay and ataxia is very, very common, usually seen by early childhood. With time, we often see a decline in gross motor function, and some children, as they get into their teen and adult years, will need a wheelchair or a stroller for longer distances. And one of the things we see in Dravet is this very characteristic crouch gait. You see there's flexion at the hip, flexion at the knee. And this often is seen by later childhood, almost all cases of adolescence. And also adults with Dravet syndrome can develop Parkinsonian features, not so much tremor, but other features of Parkinsonism that can respond to L-DOPA in adulthood. Sleep is a big concern, and 75% have, in one study, were found to have sleep problems on a standardized sleep questionnaire. And then GI issues, constipation and poor appetite are also commonly seen. And children with Dravet syndrome often are smaller than neurotypical children. Moving on to Lennox-Gastaut syndrome, this is data from the Lennox-Gastaut caregiver survey from the LGS Foundation. And again, we can see very significant comorbidities. So about 2/3 of children unable to read, unable to write at all. About 60% are nonverbal. We see behavioral concerns in more than 50%, including agitation, aggression, impulsiveness. You can see sleep disorders, again, very, very common, nearly 90%. Autism diagnosed in about 25%, but again, underdiagnosis can be an issue. And then many children will require, for longer distances, wheelchair or adaptive strollers, and feeding tubes in about 25%, and that can become more problematic in adulthood. Looking at intellectual function, so we know that children with Lennox-Gastaut usually have intellectual disability at the time we're making the diagnosis, but about 95% have that by 5 years. 80% will actually show a decline in more than 15 points over time. And that's, again, not so much that they lose skills, it's just that they fail to gain the skills at the expected rate. And then by adulthood, most of them are having at least moderate or greater intellectual disability. Behavior can be a big concern, particularly in adolescence. Hyperactivity, aggression, autistic traits. Sometimes those can be worsened by difficulties with communication. They can't convey what they're feeling, and so that comes out as behavior problems, and that can be tremendously impactful on quality of life for the family. Looking at sleep, again, we know that sleep is a big concern. Many children with LGS are having nocturnal seizures, the tonic seizures that can result in repeated wakening at night. And then this can lead to excessive daytime somnolence, which can be worsened by anti-seizure medications. We've already talked about gait problems, and we see a deterioration in about 1/5 of patients with time. And then some patients can also have increased difficulties with feeding. And it's not unusual that an older adolescent or adult with LGS may ultimately require a feeding tube. And then SUDEP is a big concern for all of our DEE patients. So here's some data on premature mortality from Dravet and Lennox-Gastaut. 2 studies in Dravet syndrome showing significantly elevated mortality rates in both. And we see here that SUDEP is a big concern. So 59% of deaths due to SUDEP in the Cooper study and 52% in the Lee study. Children with Dravet can also develop cerebral edema, and that's seen predominantly in young children following a prolonged status with high fever. And then we can see here Lennox-Gastaut studies from the US, from Germany, and from the UK show significantly elevated mortality rates compared to the general population. Some of those are seizure related. Some of those are not seizure related. They're due to profound neurological disability, things like aspiration pneumonia. And this all has a tremendous impact then on the quality of life of patients. Here is data from Andreas Brunklas's study looking at the PEDS QL in really all areas of assessment on the PEDS QL. The children with Dravet syndrome, shown here in red, scored significantly lower than the normative population. And this also has a tremendous impact on caregiver well-being. So this is data from Dravet caregivers using the EQ5D quality of life. And we can see here that greater than moderate anxiety and depression was seen in 1/3 of caregivers, and greater than moderate pain and discomfort in 25% of caregivers. And in Lennox-Gastaut as well, we see significant concern. So this is the SF36 completed by LGS caregivers. They actually don't do badly on the physical component score, but where they have more significant concerns is the mental component score. This is very, very impactful having a child with this diagnosis. And then here is data, again, from LGS caregivers. We see moderate to severe depression in a quarter of caregivers and moderate to severe anxiety in almost 60% of caregivers. So these are very, very challenging disorders. You never really know when you're going to be ending up in the ER with status epilepticus. And it's just a very challenging situation. Many parents or many caregivers of persons with developmental and epileptic encephalopathies, this also has a tremendous impact on their ability to hold down a job, and thus leads to financial stress also for these families. So a study in Dravet syndrome found that 45% of parents had either quit, retired early, or in fact lost their jobs due to caregiver demand. And the impact on mothers is greater. So half of moms versus only 7% of dads reported interrupting their work for at least 6 months due to their child's health issues. Looking at the impact of seizure control on quality of life. This was an interesting study where they gave vignettes to caregivers of persons with developmental and epileptic encephalopathy. And the vignettes included, specific comorbidities, degree of medication resistance, and seizure frequency. And I think what is shown nicely in this study is that seizure frequency does have a tremendous impact on quality of life, both for the patient up here, as you can see, and the caregiver. And this is data from the UK and France. We can see here with increased seizure burden and decreased number of seizure-free days, there is a decline in health-related quality of life. So one of the questions that often comes up is, if we improve seizure control, can that actually benefit comorbidities? And here I think it really depends on how much of an epileptic encephalopathy component there is versus developmental encephalopathy. So earlier and better seizure control is expected to improve epileptic encephalopathy, but probably not developmental encephalopathy. We are, however, in the era where we're starting to see some trials coming out of precision therapies, and that's really exciting. And if we have a precision therapy that targets the underlying pathogenesis, the hope is that this may also address the developmental encephalopathy to a variable degree, but it will be really critical to make that diagnosis early and to use that therapy early, because as the stroke neurologists say, time is probably brain in this situation. Looking at data from infantile epileptic spasm syndrome, there is some nice data to suggest that earlier diagnosis and earlier treatment, earlier control, in fact, improves cognitive outcome. This is data from the UK infantile spasm study, and this is looking at here the lead time to treatment and the Vineland Adaptive Behavior Scale in the longer term. And we know that higher scores here are better. And you can see here, the earlier we make the diagnosis, the better the child does. If we are very late making the diagnosis, the Vineland the score is lower. And this is also the situation for children who have drug-resistant spasms and ultimately go to surgery. And this is data from UCLA. And you can see here, the longer the seizure duration before you go to surgery, the lower your post-operative Vineland. So really, time is of the essence here. In Dravet syndrome, we know that there is a risk of wrong medication. So certainly using sodium channel blockers in these children markedly worsens seizures in the vast majority of kids. What it also does is has a negative impact on long-term development. And this is looking at the DQ scores. In red are children who were treated with a contraindicated medication, a sodium channel blocker, for longer periods of time. In blue are those who were not treated with a sodium channel blocker or only for shorter periods of time. And we can see here, in addition to worsening seizures, it also leads to a lower developmental quotient long-term. And this is data from the French group, and this is looking at adults with Dravet syndrome. And they looked at what was the seizure frequency during the last month in adulthood. And then they compared those in patients who were started on stiripentol, which is a sort of more precision therapy for Dravet syndrome. So those who started stiripentol earlier in blue versus later in orange. And again, we see that those who started stiripentol later appear to perhaps have more frequent seizures in adulthood. And then this is data from the fenfluramine study in Dravet syndrome. It was a post hoc analysis. And what they did is they correlated executive function, and that was based on the parent completed brief scale with seizure reduction, and said, if there is greater degrees of seizure reduction, is there improvement in executive function? In green are those children who had greater than 50% reduction in seizures, and in gray, less than 50% reduction. And we see here that greater seizure reduction improved emotional regulation and improved cognitive regulation, but did not significantly improve the behavioral regulation index or the global executive composite. So we've already talked about comorbidities and said these are the rule, not the exception in developmental and epileptic encephalopathies, and they are usually multiple. So many of these children have sleep issues and intellectual disability and behavior issues and motor and gait problems and feeding problems. And they have tremendous impact on the quality of life of the child and the family. And many of them are treatable. And I think it's really important if we're managing these patients, we do need a multidisciplinary team. So people that are experts in GI, people that are experts in sleep to help manage these concerns. Family and caregiver support is really essential. And so these are really life-changing diagnoses for the family. When we're making these diagnoses, we need to be sure that we spend time with the families to educate them so they understand what the long-term implications of this diagnosis is. And that's a very difficult conversation. We also then need to partner with parents and caregivers to decide what are the optimal treatment goals for them. We want to be sure that we have support for them, in-home support, community resources, and school support. And so having an experienced social worker really is critical. And one of the very positive things on the internet is to connect families to other families that are dealing with similar conditions. And so through the Rare Epilepsy Network, there are groups of families with these rare conditions, Dravet syndrome, CDKL5, Lennox-Gastaut, other genetic DEEs. And so it can be very, very, I think, empowering for families to connect with others who are kind of walking the same walk. So to conclude, developmental and epileptic encephalopathies are about much, much more than just seizures. We see comorbidities are nearly universal and they are multiple. Both seizures and comorbidities profoundly impact the quality of life for the child and the family, and that's the caregiver as well as siblings of that child. And can we improve these non-seizure symptoms and quality of life? Well, we certainly want to optimize seizure control to minimize the epileptic encephalopathy component. Optimizing seizure control, however, doesn't necessarily mean complete seizure freedom. That's often not an achievable goal. We want to identify the comorbidities and address those. And we want to provide ongoing support to caregivers and families. Thanks very much.
Thank you very much, Elaine, for that comprehensive overview. If I could just ask one quick question, just remind everybody to put any questions that you do in the Q&A at the bottom of the screen so that we can address those at the end of the talks. But just one thing I wanted you to just expand a little bit is when we're thinking about treatment, how do we decide what our specific goals may be, or how do we assess that in these children, knowing it's may not just be the seizures, or the seizures may actually not be the main issue?
Yeah, I think that's a good idea, or a good comment. I think one of the things we really need to do is to continue to partner with the parent and the caregiver. What I typically do from a seizure standpoint is identify what are the most problematic seizures to them. So for example, in Lennox-Gastaut, it's often the drop seizures. In Dravet, it's really trying to prevent those prolonged convulsive seizures. And then also look at, what do we know about that particular disorder? And do we think this is predominantly an epileptic encephalopathy, or is there a developmental encephalopathy component? And really really what are we likely able to achieve? Because I think what we don't want to do is continue to throw more and more and more medications at that child when the yield of improving seizure control with that is very low, and where we are likely going to, in fact, exacerbate those comorbidities, right? The sedation, the gait difficulties, ataxia behavior, things like that. And then it's really identifying the comorbidities, as you say, those are often more impactful. And I think to recognize that those may need different treatments. So if somebody, for example, a child with Lennox-Gastaut has significant behavioral issues and is still having a few seizures, those are really unlikely to go away with better seizure control, even if you could achieve that. And so making sure that you partner with your behavioral health specialist to work with that family and work with that child.
Thank you, Elaine. Thank you. I'm sure there'll be more questions at the end. So now I'm going to proceed with talking a little bit about cognitive and behaviour problems seen in surgical candidates in children, and whether we can make any impact and whether we can predict that impact. A bit of delay. That's it. Great. Here we go. So when we're thinking about epilepsy surgery, we're of course thinking about the removal or modification of part of the brain with the aim of alleviating seizures. And there's no doubt the vast majority, if not all, candidates that come to surgery, our primary goal is to relieve seizure burden. In the majority, we're aiming for seizure control, although some we know that percentage chance might not be as high, and we're at least trying to relieve the seizure burden they have. But that said, there may be secondary goals, particularly on the part of families of children with early onset epilepsies, and not least that will we see any improvements in their neurodevelopmental progress or indeed improvements in their behaviour. So what evidence base have we got? Firstly, what would happen if surgery wasn't undertaken, if they continue to have seizures? And of course, it's very difficult to look at directly, but if we look at some studies that have looked at children longitudinally, this is data from Anne Berg's Connecticut study, where she recruited all children presenting with epilepsy over a period of time. And this particular data looked at serial Vineland data over the initial 3 years of life. So there was a baseline score, and then at 1, 2, and 3 years following presentation, the vast majority of these individuals continuing to have seizures. You can see that actually over time, there is, in whatever domain is being viewed with the Vineland, there was a steady decline over time, which indeed was significant. And when looking at later data at a later stage, looking at 8 to 9 years following seizure onset, and in this, under the age of 8 years, there was a strongly association between IQ and indeed age of onset in the pharmacoresistant group. So in those that continue to have seizures, resistant to medication, with an earlier age of onset, there was a lower IQ. And this is something we've seen across many different studies. And this we tried actually to look, accepting that it's difficult to now follow patients who are not going to have surgery over a long period of time if they've been evaluated for surgery, because that's what we advocate. But this is data from an epidemiological study that we undertook in North London, where again, we recruited all children with seizure onset under the age of 2 years, presenting over a geographical area of North London, and looked at their IQ at baseline at 1 and 3 years. And their actual function at baseline, whether it was within the normal range or not, it was lower if there was greater than 20 seizures prior to assessment, maybe related to the number of seizures, but maybe related to the actual underlying disorder, and an abnormal neurological examination. And then at 3 years, a lower IQ associated with a lack of seizure freedom, and actually was also predicted by the baseline cognitive score. So I'm now going to ask you another question. And which of the following is true? Following epilepsy surgery, improvements to cognition are seen in all children immediately. Improvements are likely to be seen in the longer term, whether seizure-free or not. Improvements to behavior are guaranteed. Or is it difficult? It is difficult to predict changes to behavior following surgery. Which of these is the correct statement? Okay, we've got quite a mixture. 52% of you feel that it's the bottom one, it's difficult to predict changes to behavior following. 39% improvements in cognition likely to be seen in all children in the longer term, whether seizure-free or not. I have to say the only one you could actually categorically say is true is the fourth, where 52% of you have agreed. So first of all, looking at cognition, first of all, we can have a look at study here on the top left is a study from the Cleveland Clinic reported quite some time ago, but actually was looking at all children they'd operated on under the age of 3 years, and then actually only looked at 9 months follow-up. And essentially, we're looking at improvements or not in the developmental quotient following surgery compared to baseline. And one of the key issues is that they were more likely to see an immediate improvement in developmental quotient following surgery if there was a history of epileptic spasms rather than if there was not. So suggesting that in a proportion, there was a treatment of an epileptic encephalopathy, a reversal of that, i.e. those where spasms have been recorded, as opposed to those that didn't. And in fact, many studies looking at pre- and post-operative IQ scores have done so over a no more than 3-year period and demonstrated actually that post-operative IQ is highly related to pre-operative IQ with no dramatic change seen. That said, you could suggest that maybe IQ with continuing seizures would drop over time as it's a measure of a performance relative to normal peers, and therefore a maintenance of IQ is a degree of success. This is a series of children that underwent temporal lobe resection in our own institution and looked at and follow-up from baseline and up to 10 years following surgery. And what indeed we demonstrated was that the IQ immediately following surgery was unlikely to improve up until 6 years following surgery, when there was then a steady improvement, highly related to seizure freedom and weaning from medication. And you could argue perhaps that there are two groups which are actually illustrated well by this study from Lausanne, looking at very careful evaluation of IQ over time in surgical candidates. You can see this top group who had an immediate improvement following surgery in their IQ, perhaps treating an epileptic encephalopathy, and the group that did not show such an immediate improvement, but gave the impression of improvements over time, perhaps due to a degree of remodeling, weaning of medication. And indeed, these are longitudinal studies that both our original temporal lobe resection sample and a subsequent mixed extratemporal and temporal lobe sample, where we can see a reduction in IQ in the group before surgery, perhaps related to ongoing seizures, stability immediately following surgery, up to 5 years following surgery, and then slow improvement over time. And again, these improvements have been demonstrated to be related not only to seizure freedom, but also weaning from medication, as well as duration of time following surgery. And indeed, on a much larger group, 500 patients that we'd undertaken surgery on between 1990 and 2018, similar findings. You can see the green line is the IQ of those that have achieved seizure freedom following surgery, and the orange, those who've not achieved seizure freedom. So patients who were seizure-free and no longer receiving anti-seizure medications showed higher post-operative performance at 1-year follow-up, but also greater improvements in neuropsychological functioning over the long-term post-operative period compared to patients who were seizure-free but still receiving or weaning anti-seizure medicines. So it's not only seizure freedom, but it was also weaning from anti-seizure medication. And this was also illustrated in our time to stop study. This was a study of across multiple European centres led by Utrecht, where they were looking at speed of weaning medication following surgery and looking at early versus late weaning of medication, but essentially looking at the effect of withdrawal of medication and change in IQ. Patients starting an anti-seizure medicine withdrawal had a significantly higher post-operative IQ. A complete discontinuation of anti-seizure medicine significantly was significantly related to a higher IQ and IQ gain. And indeed, the number of anti-seizure medicines that were reduced postoperatively were linearly related to IQ and change in IQ. The more drugs withdrawn, the higher postoperative IQ and the more increase in IQ. So it seems we're not only going for seizure freedom, but we're also looking to wean medication. Perhaps the medication is actually doing more than we originally thought. So what about behavior? Well, this is a systematic review looking at studies that have evaluated behavior pre and post-surgery. And indeed, this was conducted by colleagues of mine, led by Colin Riley. And you can see that there were 15 studies that met the inclusion criteria where they were able to evaluate pre and post-operative data outcomes. There's no doubt they reported that the majority of studies employed parent report screening checklists. So you could argue, is this really an assessment or diagnostics when looking at perhaps even DSM-4 psychiatric diagnosis? But that said, scores were reported to have significantly improved at follow-up in at least one domain in 7 studies with no change in 2, and no study reported a deterioration in behavior. And in studies, albeit limited, that did use DSM criteria, no significant change was seen in the number of patients proportionately diagnosed preoperatively as opposed to postoperatively. And we can see that in 2 of the studies that we've undertaken. These are studies in a temporal lobe resection population and an extratemporal resection population. In the temporal lobe population, we could see that we evaluated 60 children and looked to give them a DSM-4 criteria diagnosis. This, if there was between 2 individuals, and if there was a debate, then the 3rd individual came in to decide what that criteria might be. But what we saw was that 83% had a diagnosis at any time, 72% preoperatively and 72% postoperatively. And the issue is that many had more than one diagnosis, some lost diagnoses, and some gained diagnoses. And a similar, although perhaps lesser a problem seen in the extratemporal group, 52% had a diagnosis at any time, but similar proportions pre and postoperatively. Again, some could gain diagnoses and others could lose diagnoses. And this actually was trying to look at the long-term behavior outcome in a group of children from Toronto that had undergone pre-surgical evaluation and ultimate surgery, although they had a group of individuals who did not undergo surgery for a variety of reasons, whether they were not candidates or whether they declined surgery or they eventually gained seizure control with medication. And they tried to look at that utilizing the child and adult behavior checklist up to 12 years following surgery. They looked at baseline and the follow-up and looked at various specific behaviors. And in general, those who were seizure-free had more of an improvement than those that had seizures, whether or not surgical resection was actually undertaken. But then, of course, there's an issue about functional outcomes, not least, what does it mean for the family? This study looks at trying to look at quality of life. And indeed, it was very difficult to determine any specific change to quality of life. There's no doubt that the odds ratio for seizure freedom was higher in the surgery group, undergoing surgery as opposed to pharmacological management. And surgery appeared to have no direct effect on quality of life score at 12 months compared to pharmacological management. It was all predominantly driven by seizure freedom or not. There was an indirect effect on total quality of life in the surgery group, and also in improving physical function, cognition, social function, and behavior, as I said, all mediated by seizure freedom. There may be a very individual component, and also are we talking about an immediate effect or even what effect happens over time? And this study, utilizing a strength and difficulties questionnaire, looked at the total difficulties score, and that's the difficulties of the child, as opposed to the impact score on the overall quality of life and family. And you can see that over time, pre-operatively and at 3 times points post-operatively, the difficulties score steadily improved over time. Whereas the impact score was much more variable and highly related to the age of child and the overall situation of the child at the time. And even the population's quite different, of course, whether it looking at functional outcomes, whether it hemidisconnection group are much more variable as opposed to a more focal resection. And this on the left was a telephone interview looking at what outcomes there were overall with regards to hemidisconnection patients. And you can see only a fifth of them in employment in adulthood, whereas much more in the way of evaluation from a quantitative point of view, but particularly less disability, independent living, and improved quality of life, and more educational attainments following a temporal lobe resection. And this, I thought, was an interesting study looking at family burden, looking at the German version of the impact on family scale in a German institution at 31 children who'd undergone epilepsy surgery. The mean epilepsy duration was relatively short, and there's no doubt that cognitive impairment also correlated with the family burden pre-surgery. But essentially, with seizure freedom, the family burden values reduced by 2/3, if not 3/4. So in summary, the rates of cognitive and/or behavior problems in children with drug-resistant epilepsy coming to surgery is high. Following surgery, there's good evidence of longer-term improvements in cognition related to seizure freedom and weaning from medication, but behavioral improvements are much more difficult to predict on an individual basis. Overall functioning is likely to be better if seizure freedom is achieved. But in view of all of this, it is really important for the aims of surgery to be discussed on an individual basis and revisited at a certain time following surgery. Thank you.
Thanks very much, Helen. That was a great overview. Can I ask you how you counsel families then because that's one of the questions that often comes up, right? When they're talking about epilepsy surgery for their child. On an individual basis, what do you say to them?
Well, of course, we have to assess them according to the ability of the individual and the severity of the behavior and cognitive development. And, certainly we can be optimistic about degree of developmental improvements, but of course, the significance of that gains are all going to be relevant to their baseline level. And there's no way that we're going to, it's likely that they're going to improve relative, where they are, but actually how much that improvement is going to be difficult to predict on a longer term basis. And we can only hope to achieve optimal outcomes with achieving seizure freedom and perhaps weaning medication. Behavior is also much more difficult. And the inevitable thought is surely if we make them seizure free, their behavior will improve. But actually in the short term, we may see a deterioration. And that's because many of the children, as having so many seizures, they may actually be quite flat. And when we actually stop their seizures, they seem to wake up and actually become much more vocal, much more difficult in the shorter term, which of course is worrying. But actually in the longer term, that seems to either out. All we can say is it is unpredictable and work with the families for the interventions they may require for rehabilitation following surgery.
Thanks very much.
Okay, so let's go to the last presentation, which is from Kette Valente from the University of São Paulo, who is going to talk to us about beyond seizures in idiopathic generalized epilepsies. Thank you, Kette.
Well, thank you for having me, for inviting me. It's a pleasure to be here. And, well, let me try to. I have no conflicts, as stated before. And regarding our statements, persons with idiopathic generalized epilepsies do not have coexisting disorders. Persons with IGE have personality disorders related to impulse control. Persons with IGE have milder personality disorders, psychiatric disorders with no impact on their lives. IGE is heterogeneous and severe cases may have poor or worse outcomes. Well, indeed, IG is heterogeneous and severe case may have poor outcomes. And in the next 50 minutes, I'll try to convince the 40% that didn't vote like this. Okay? Thank you. So under this large umbrella of idiopathic generalized epilepsies, we have 4 epilepsy syndromes. Of course, it's impossible to address all of them. So I'll be talking about juvenile myoclonic epilepsy because occurs very often. It's prevalent in adolescents and young adults and adults in general. So the cognitive and behavioral psychiatric profile is better delineated. It is genetic, as demonstrated in twins and triplets. It is generalized by definition, so we have the W of Jens, and the seizures are generalized. All patients will have myoclonic seizures, and 8% will have generalized tonic-clonic seizures or myoclonic tonic-clonic seizures that usually last longer than generalized tonic-clonic seizures. We have a myoclonic burst followed by generalized tonic-clonic seizures. And 30% will have absence seizures. The diagnosis criteria based on the Avignon consensus show clearly that we don't have a homogeneous syndrome. 70% will have the classical JME, with myoclonic seizures occurring on awakening. EEG is generalized, normal intelligence, and the age range at onset 13 to 25. But we have 30% that will have myoclonic seizures not only during awakening, they have more frequent seizures. The EEG may have focalities and asymmetries, which may delay the diagnosis. There is no mental retardation or intellectual disability is a better term, or deterioration, but not always normal IQ. And the age at onset ranges from 6 to 25 because some of these patients evolve from absence in childhood to juvenile myoclonic epilepsy. So 70% will have the classical type, and 30%, I would say, non-classical, not atypical. We have endophenotypes as described by Delgado-Escueta. The prognosis, despite the fact it is idiopathic, is not so good for all patients. 15 to 30%, it depends on the series, will have drug-resistant seizures. So we have a generalized epilepsy with generalized seizures. It is genetic, no doubt. But what about this empty ellipse here? Well, since the pioneer description of Jens, we have that patients with or persons with juvenile, according to Jens, persons with juvenile myoclonic epilepsy or the petit mal would have impulsivity, emotional instability with a negative impact on daily life, not only treatment. Indeed, over the years, different groups and different studies corroborated these findings. And we, using classical neuropsychological testing, they described what's called cool or cold executive function that comprise attention, that comprise inhibitory control and mental flexibility, but also those that are emotional related, and they are labeled as hot executive function. That means mainly decision making. So these patients, they have difficulties, not all of them, but most of them, to make decisions, even when they know the consequences, meaning That's why they may decide not to take their medications or to expose themselves to sleep deprivation or things like this when they know that they may have seizures. Do they perceive themselves as dysfunctional in this sense? Yes, they do, considering the executive impairments and the impulse control, using self-assessment scales that are complementary scales that we must use or we can use after a traditional comprehensive approach, as demonstrated before. Is this restricted to patients? Not really. So we have juvenile myoclonic epilepsy in twins and triplets and siblings, but not only epilepsy. We may have in siblings that do not have epilepsy some executive impairments, different types, but we may have. So the traits are not related to only epilepsy. Considering psychiatric disorders, the School of Marseille gave a great contribution. So the prevalence of psychiatric symptoms at that time not classified according to the DSM, so we have to say symptoms, but not disorders, was 29 to 30%. Now we know that disorders are 30%. And based on the reports and the studies from Genton and Jalisi, we know that not all patients are the same. So patients with drug-resistant epilepsy, they have higher rates of psychiatric disorders. Again, using the DSM-4, 26.5 to 30% a psychiatric disorder, but not all personality disorder. We have anxiety a lot and sometimes mood. Personality disorders, they are mainly about impulse control, which overlaps with what we saw in executive function impairment with inhibitory control, but they are mild to moderate. So when we discuss personality disorders, we have a tendency to think about borderline personality disorder, and it's not like that. We don't have here self-mutilation. The suicide rates are very low. So be careful. The authors had to stress this some years later because of the rates that were getting too high in different studies. In order to clear this, in order to illustrate better, some groups, including our groups, have used some, not screening, but some rates, some tools that we can rate impulsivity. The most famous one is Cloninger. It's extensively used in the psychiatric field for impulsivity, because sometimes you cannot classify someone does not meet the criteria for impulsive disorder, but has impulsive traits with impacts on this person's life. So we use the Cloninger inventory. It's 108 questions. It's hard to, but we had a very nice group of patients. And what we saw is that they have higher scores compared to controls in novelty seeking. They like what's new, and they get bored easily with daily activities. However, surprisingly, they also have higher rates in harm avoidance. This is not seen in other types of personality disorder. The rates of harm avoidance, they are very low. For example, in pathologic gamblers, they do not respond to feedback, negative feedback, which is good. So we may have here a milder profile that is more responsive to feedback. So I think our empty ellipse is not so empty. We have good evidence that these patients, some of them, may have difficulties with impulse control, with attention, executive function, and especially with inhibitory control. But are they all the same? Apparently not. When we were assessing patients with classic JME, 63% of them had executive and attentional deficits, 40% did not. But when we look at here, we just see pure and simple executive impairment. The group from UK actually assessed drug-resistant JME, and here we had 66%. 66 and 63 is not so different, but let's look at the type of impairment that they found. IQ and memory, this is not something that you see in patients that are easy to control. So there is a spectrum of severity that was very well demonstrated in what I called hot executive functioning, meaning decision-making. Seizure-free patients are very close to control, but drug-resistant patients, we have to give special attention to them. In order to make things clear, we had a more homogeneous group of patients. These patients, they all had classic GME. We excluded non-classic GME. They were all receiving the same anti-seizure medication in different doses. So we don't have patients under polytherapy. We didn't have too many confounding factors. So patients with harder to control seizures indeed had more impairments in different aspects of executive function, but more than this, they also had worse performance in memory tests. So they performed worse in executive function, memory, and also in impulse control. They were more impulsive. So it seems like we have a combo. Patients that are harder to control also perform worse in everything. What is the impact for them? Well, impulsivity has a higher impact or impacts different aspects of social adjustment, not quality of life. Social adjustment more than seizure control. Seizure control impacts work, especially generalized tonic-clonic, but impulsivity impacts work and their relationships, including marital relationships. So it seems that we have a spectrum. Patients are impaired in different ways. We cannot generalize these findings. It may be a hallmark of juvenile myoclonic epilepsy, but we will not see the same in all patients. But we have to pay attention to impulsivity and executive dysfunction because it will have a practical and clinical impact in adherence to treatment and risk behavior. This is important for morbidity, and we discussed this over and over, social adjustment and everything else, but also we should not forget SUDEP. Although we discuss SUDEP a lot for focal epilepsy and drug-resistant epilepsy, in the North American SUDEP registry, there is an overrepresentation of patients with JME. Their breakthrough seizures are generalized tonic-clonic seizures. And if you have a group that's harder to control and does not take their medications properly, we may have a problem. Can we improve this? Can we improve impulsive control? Can we improve these executive impairments? It seems that we can. We don't have studies about this. These are just preliminary findings. And we use the rehabilitation program that we adapted from ADHD. Here, it's important to say that we excluded patients with personality disorder because for personality disorder, we must use dialeptic therapy, not this type of therapy or cognitive rehabilitation. Then we had an improvement in selective attention, inhibitory control, mental flexibility, and decision-making. That is extremely important. These patients, they perceive the difference. Okay, this is objective measure, and this is what I say, subjective, although it's not so subjective, it's based on self-assessment. They improve it in modulation of emotional control, which is important for impulsive control. They improve in attention and symptoms using a scale that we use for ADHD in adults and in their impulsive behavior. It may have an impact on different aspects of life. So summarizing, patients with juvenile myoclonic epilepsy may have behavioral and psychiatric disorders, particularly mood, anxiety, in 30 to 40%, executive dysfunction, perhaps in 60 to 66 or 70%, it depends on your sample, impulsive traits that range from traits to disorder, and for some, we may have an impact on adherence to treatment, and we also may have more risk behaviors. So think about, diagnose, inform your patient, because this inform is a psychoeducational process. And when they know, they start recognizing, and this is a form of treatment. So treat beyond seizures. This is the message. Thank you.
Thank you very much, Kette, for that great overview. Just one brief question before we go to the question and answers. You talk about rehabilitation for the executive function. Does it make any difference beyond that? Do you see other changes or improvements?
Actually, we measured that, and what we had is, first, there was a decrease in anxiety. They were more competent to make decisions and to organize themselves, which is a problem. So they felt more confident, the anxiety levels decrease, and also the adherence to anti-seizure medication. So it improves our treatment. This is the thing. And we usually think we have discussed treating seizures to improve behavior and cognition. And here I would like to invite you to think in a different way. Let's treat cognition and behavior to improve the treatment of seizures. Then we may...
Thank you. Thank you. So now we'll move to the question and answer session. We have some questions that have come in. If anybody else has questions, please put them in the question and answer box at the back, and I will try and address as many as we can. So one of the questions that's come in is there any epileptic encephalopathy specific in the elderly? And I think my initial, I'll answer from the start and then come to perhaps one of my colleagues to comment. I mean, saying that is there a specific one, I think is unclear. But the thing is that as far as I'm aware, the elderly may be more prone to non-convulsive status, which is undiagnosed, whether it's related to being seen in Alzheimer's or post-stroke. And subtle cognitive deficits may happen that are maybe attributed to something else. And we find it's the result of non-convulsive status, which is indeed possibly treatable. I don't know whether either of you have got any comments on that, considering we're all pediatricians, but...
Yeah, I think that's certainly true. I think the other thing that we did when we defined the epilepsy syndromes is we do recognize there are some syndromes that don't really fit into the DEE because they're not really developmental and epileptic encephalopathies because they come on after a period of prolonged normal development. And so we called those epilepsies with progressive neurological deterioration. And so examples of those would be an adult, for example, who develops a progressive myoclonus epilepsy, who then has regression. Now that's part of clearly the underlying etiology, but probably also the frequent seizures are impacting there, or an adult late onset Rasmussen syndrome. So there are some that can come on later in life, but I fully agree with you. I think that if you have an adult who is having very frequent seizures, sometimes that can have a negative impact on cognition. And if we can improve that, we see the cognition improve again. So it's sort of like a pseudo dementia type picture.
Thank you. Okay, there's a question here. Can epileptic spasms affect the mental health of a pediatric patient? I presume this really is related. Do we see behavior problems following infantile epileptic spasms? Kette, do you want to comment on that?
Yeah, epileptic spasms can affect everything. If you have a deterioration, it's not only cognition. And if there is a deterioration of cognition, behavior will be part of the process. So we cannot, this is something interesting. We have this idea that we can put cognition in one box and behavior in another box, but actually they are all related. So yes, of course.
Thank you. Okay, there's a question again, post-surgical, well, this time post-surgical, any evidence of correlation between long-term improvement of cognitive function or how soon or how quickly is medication is weaned off post-operatively? I don't think we've seen any direct correlation between how long it takes, just the correlation that it's better outcome if we're able to wean medication. I did warn my colleagues that the camera might fall. Anyway, but I think what we have to think of is that the earlier we do it, the earlier the surgery, the earlier we wean off medication, the better the chance of long-term improved outcome. We also, there is the question about, you know, who do we wean the medication is? Are we at if we wean it early, is there an increased chance of seizure recurrence? And that was a question addressed by the original Time to Stop study, where they were looking at early versus late medication wean. And essentially looking at in excess of 700 patients across Europe. In those where, you know, we would all wean according to our program. In fact, the earliest we were weaning at that stage appeared to be a year post-op. And indeed, when they saw seizure recurrence from their statistical analysis, this was seizure recurrence that was likely to be inevitable, not because of the wean of medication. So that actually says we should be attempting to wean if they're seizure-free following surgery. They were then going to go on and do an early versus late medication withdrawal and compare outcomes. But it turned out that everybody had changed their practice to an early wean, namely if we felt they were in a really good prognostic group, we were confident we'd got the whole lesion, they weren't having seizures, we're weaning first medication as early as 4 months. And this seems now to be wider practice. And so it was impossible to do that early versus late study. There's a question here about why interictal epileptiform discharges frontally dominate. Who would like to address that one? Kette?
I think this is about the IGs, probably.
Yes.
About there is an interaction between the thalamocortical loop with the frontal lobe cortex. So that's why there is this predominance on the frontal lobe cortex, but it's not always there. Indeed, you are right. There is a predominance on the frontal lobe cortex, and it's about this loop between thalamus and the frontal lobe. But not always. Be careful. We have focalities everywhere. Just be careful of this.
And then there's another question about GGE. Is there any possibility of withdrawing anti-seizure medications?
Actually, there are some very interesting studies in the German group that followed those patients that were described by Jens for years. And also there are other studies, but from German, they are very nice, that 20% of these patients, we could stop medications, especially those, and they have some tips about our predictive things, like those that are easy to control from the beginning and they don't have myoclonic seizures or any other types of seizures with low doses of anti-seizure medication. This is the group that may have a chance to stop. To be very honest, I think that we always, if you have this patient, you have to discuss with them very open-minded way, because some of these patients, they may have a chance, but they may not wish to stop because they may need to stop their activities like driving. So
Okay, thanks. There's a question here very specifically for you, Elaine. Would you mind elaborating more about developmental epilepsy dyskinetic encephalopathy and the genetic cause? I think it's more developmental epilepsy with movement disorder, developmental epilepsy dyskinetic encephalopathy, and whether about the genetics and specific treatments.
Yeah, so I think that some of the developmental and epileptic encephalopathies, and there is now, I think Ingrid Sheffer has told me 1,000 genes. I think we've hit that number that cause this. And so some of those genes can also be associated with movement disorders. And so I think, you know, in an unexplained case of a DEE, we do need to do genetic testing. I think in most cases, there is not a specific treatment that we would use uniquely for that particular gene, but many of these children can respond to other therapies that we would typically use to treat movement disorders. So typically then involving your movement disorder specialist and trying to get a better handle on dyskinesia or whatever is the movement disorder associated with that.
Thanks. There's a question here about how much percentage of epilepsies lead to cognitive change. I think there's two ways you can look at this. Number one, you know, we've got the group data that around 55% of children or school-age children with epilepsy have cognitive impairment, much of which goes unrecognized apart from in the severe group. But then there is also the issue, which percent of the epilepsies or even each individual epilepsy lead to cognitive change? And that's much more difficult. There is the possibility, actually, of any of the epilepsies having an epileptic encephalopathy. You know, even in in self-limited epilepsy with centrotemporal spikes, cognitive impairment with the spikes has been noted. So in a way, that is a degree of epileptic encephalopathy. But, you know, it's a fact that some epilepsies, that individuals may be more prone to an epileptic encephalopathy than others. And it does have to be weighed up on an individual basis. I don't know if you want to add anything, Elaine?
No, I agree with what you've said. I don't think I have anything further to add.
Okay, all right. There's quite an interesting question here about whether we should be using a phenotypic approach to the classification of the epilepsy syndromes in terms of their cognitive and behavioral as well as their neurological features. And I think I'll go to you, Elaine, first, and then you can add, Kette.
Yes, I would say that epilepsy syndromes, the approach really should be phenotypic. So we should be looking at the phenotype of the clinical presentation, the seizure types, whether or not there are comorbidities, intellectual disability. That often helps us sort of they're clues to a patient having a specific syndrome. And then, you know, phenotyping also the EEG characteristics, right? The background, the interictal discharge. So I think epilepsy syndrome is very much phenotypically focused. And then I think, you know, with any of the epilepsies, as you had mentioned, there are some that very commonly are associated with cognitive impairments or behavioral concerns or other comorbidities, and those are the developmental and epileptic encephalopathies. And so I think phenotypically, if you have a very significant issue, you know, that's a clue that maybe they fit into one of those, but you don't want to say, well, if they don't fit into that, they don't, because many epilepsies, as you had mentioned, can also have, you know, periods where they have more frequent seizures, even what we would otherwise think of as the self-limited or the more well-behaved epilepsies can certainly have some cognitive and behavioral issues there too. So I think we just have to keep those issues in mind with any person with epilepsy that we see.
Thank you. Kette, do you want to add anything?
This question came from Eugenia Rosa, that is a bright person in the young epilepsy section. And this is the thing about giving nice lectures in San Severo, Elaine, because she was there with us and this was discussed there. Eugenia, I think you are right in what you are talking about. And it's about the ellipse that is empty. This is what we are discussing here today, that it's part of the approach that the ILAE is having now, that we have to delineate these syndromes, the epilepsy syndromes, taken into account the cognitive and behavioral aspects, but it's not as easy as it sounds, because in these we have multisystemic disorders. And also we have to remember that everything that I mentioned for IGs, they are not specific. This is something that we must keep in mind. We may see in other things like in frontal lobe epilepsy.
Thank you.
So,
I've got a question here about in infants under 3 months of age, structural etiologies dictate that patients are unlikely to benefit significantly from pharmacological interventions. The question arises, can we assess the candidacy of a surgical intervention at an earlier stage rather than waiting until a definitive diagnosis of drug-resistant epilepsy? And the answer is yes, and not just under 3 months of age. I think epidemiological data from many groups, not least from people here, is shown that, you know, if you have a structural etiology, the likelihood of long-term seizure freedom is slim. And therefore, what many of us are advocating is if you've got clear data that there's a definite structural abnormality and that you're convinced that the seizures are coming from that area, if there's any doubt, then you have to have more careful delineation. Then, and it's in a non-eloquent area, why not? I mean, and yes, this decision-making may be, you know, easier perhaps in the very young than the older group, but if it's in a non-eloquent area that's easy to access with low risk, maybe we should be operating after just a trial of one drug. And no, we don't need to wait for real drug resistance. I mean, actually, drug resistance in a very young child with a structural etiology is likely to be achieved within a very short period of time because it's a trial of 2 drugs for a sustained amount of, you know, it's a decent dose and 2 appropriate drugs. It doesn't mean any appropriate, you know, any definitive length of time. So I think, you know, we do have to weigh all this up. And that's why our decision-making is coming earlier with regard to surgery. Obviously, in older children where they've got focal onset, it's difficult to delineate the lesion. It may be even lesion-free. It requires a much more careful workup, and you've got to weigh up risk benefits of continuing medication versus the surgery. But, you know, when there's a definitive, well-circumscribed structural lesion and you're convinced the seizures are arising from there, then there's no reason why it shouldn't be removed if it's low risk. Do either of you want to add anything to that?
I fully agree. I think sometimes in the very, very young children, it's sort of balancing surgical risk at that very young age. But I think, you know, even in the first year of life, I think we can do epilepsy surgery quite safely. And if you know the writing is on the wall and you're really trying to save development, that would be a good reason to go forward.
There's a question here. I'm not sure I've interpreted it correctly. So if the author feels that I haven't, then please type it in again. It says, in patients operated on with DCF, the suspension of treatment, how long does it take? And I presume they mean, you know, if we operate and we decide to wean treatment, how long does it take to wean treatment? And usually most anti-seizure medicines, we would say we wean over 2 to 3 months. There are some we take longer, such as the benzodiazepines. We may take up to 6 months to wean because you can get problems with withdrawal. But most of them, if we make a decision we're going to withdraw, we withdraw one at a time. I usually withdraw one over 2 to 3 months, wait a month, and then if they're fine, I'll withdraw the next one. Do you follow a similar practice?
This question is about focal cortical dysplasia. It's written.
Thank you. That's it. Focal cortical dysplasia.
Yeah. It's written like for someone that speaks French, Italian, Portuguese, or Spanish because it's
so FCD. It's the reverse.
Yeah.
Thank you, Kette. I was having a bit of a problem. So Kette, FCD, focal cortical dysplasia. Yes. I mean, if we're really convinced that we're well circumstanced, prescribed, we've removed it all, then that's the plan I would have. If there's any doubt, I might take longer, you know, because if we think there may be some left, then they may run risk of having further seizures, and I may leave them on one anti-seizure medicine for a longer period of time. Yeah. Okay. Behavioral issues are common with epilepsy. Should all adolescents have genetics to rule out related neurodevelopmental disorders? Elaine.
No, I think that we're using genetics really to look at underlying etiology. I'm not sure how much genetics actually help us with that. I think it's a clinical diagnosis. So for example, if you had a patient with clear-cut juvenile myoclonic epilepsy, I would not do genetic testing on them because I think that would be very low yield. If you have an adolescent with unexplained epilepsy with significant intellectual disability, then and you don't have an underlying cause for that, then I would do genetic testing in that patient. But I would not do genetic testing just to look for neurodevelopmental disorders in everyone.
No. Okay. There's a question about what panels we use for looking at things. I think rather than say one's better than the other, it's what you have available and what's available within your resources. We in the UK, well, no, we in England have whole genome sequencing available to any child, any individuals had onset with epilepsy under the age of 3 and or learning disability in association with that epilepsy. But that is something, you know, we've had available, but it's not the same everywhere. And I think the issue is what you can get within your resource is what's appropriate. Yeah, I have seen nodding. Okay. Okay, and there's one last question about data about burden of visual impairment beside behaviour following surgery. I don't think there's any specific studies that actually look across the board. I know there's very specific studies that have looked at hemidisconnection and also occipital lobe resection, looking at behaviour, visual behaviour, maybe even how much the other side is functioning. But there's nothing looking across the board at visual impairment and how that changes. Okay, I'm conscious we're running out of time, which is why I'm speeding up. I think it's great. Thank you so much to our speakers, Elaine and Kette, for the contribution and the discussion. Thank you to all participants for the active discussion. As I've said, moving forward, you will, at the end of this, be provided with an evaluation form to complete. Please do, because of trying to organise future e-fora. And then tomorrow you will also receive an email on how to access a self-paced virtual case to consolidate the learnings that you would have had from today. That goes for me to say nothing more than to keep an eye on our social media pages and our website to learn more about other educational events from the ILAE. This particular e-forum will be available from tomorrow as a recording. Thank you.